and I will ask you that you share your slides and you take over. Thank you.
Thank you very much, Dr. Marvin, and good morning to everyone. So today we shall, as Dr. Marvin has said, we shall be going through benign prostatic hyperplasia, and later on looking at prostate cancer. So this is a topic that is of importance, especially in urology, because in your practice and as you review patients, you are going to see multiple patients that actually have benign prostatic hyperplasia. Just going through a brief anatomy of the prostate. The prostate is a walnut-shaped gland that sits at the base of the male bladder. It is a gland that is surrounded by the urethra, that surrounds the urethra. And its main function is to produce the fluids that help to transport sperm during ejaculation. So what is important to know in as much as prostate is concerned is that it actually grows with time in the males, and there are two phases of growth. The first phase is in the early 20s, and then the second phase is in the mid 40s. So we shall see the importance of this as we proceed. The other aspect is that in as much as the anatomy is concerned, the prostate is mainly divided into different lobes. So we have what we call the anatomic lobes, and we also have surgical lobes. So the anatomical lobes are actually 5. We have one anterior lobe, we have one median lobe, one posterior lobe, and 2 lateral lobes. And then for surgical purposes, which is what usually causes the symptoms, the main ones that are concerned are the 2 lateral lobes and the median lobe, which are the ones that usually cause the symptoms that patients with BPH present with. So looking at BPH specifically. So BPH in prostatic hyperplasia. So the word benign condition, and then prostatic, of course, that it is from the growth of cells than what you would normally find. So the definition of BPH is that it is a non-malignant hyperplasia of the prostate, studied extensively, and they have found that the prostate is to 2.5% increase in size every two years. So these years are mainly concerning the group that is in the late 40s. So it is a common cause of lower urinary tract symptoms, which are seen in men. So as we continue the presentation, we shall refer to lower urinary tract symptoms as LUTS, as we shall see during the presentation. There are other definitions that have been used in literature, which whenever you meet them, you have to always think about their link to BPH. So these include BPH. So the term BPH, when they are using it in literature, it usually describes the histological changes that we talked about, that there is overgrowth of the cells within the prostate. And then we also have bladder outlet obstruction, which basically describes the obstruction to the flow of urine. So this bladder outlet obstruction is usually due to the three lobes we talked about. We talked about the median lobe, and the two lateral lobes. So what is of note, in as much as bladder outlet obstruction is concerned, is that you don't necessarily have to have all of the three lobes enlarged in order for you to have a bladder outlet obstruction. But it can be either the lateral lobes that are enlarged, or it can be the median lobe. So usually for the lateral lobes to cause obstruction, they need to grow significantly in size, approximately above the 50 grams, as we shall see as we continue. But in as much as the median lobe is concerned, it only needs a small amount of growth in order to cause obstruction, and that is about 20 grams to cause the obstruction. And then the other definition, as we have said, is the lower urinary tract symptoms, which basically talks about the urinary symptoms that come with the affectations of the bladder and the prostate itself. And it is usually exclusive to men. And then benign prostatic enlargement is another term that can be used to describe the increase of size in the prostate itself. Now looking at the prostate, we have said that the prostate is usually walnut shaped, and it grows with time. So usually as the prostate enlarges, the pressures can be put on the urethra, causing urinary symptoms. So as we see in the second image here, when the prostate is, the image on the right, the prostate is quite enlarged, and that results in a poor emptying of the bladder. So even after voiding, the patient might present with the residual volume of urine within the bladder. And then the other aspect is that the prostate size does not really correlate with the degree of obstruction or the severity of the symptoms. Like I alluded to earlier on, that a small increase in the median lobe will cause more obstruction compared to what is needed for the lateral lobes to actually cause obstruction. In as much as epidemiology is concerned, so the age is an important factor. As old, half of them actually affected by BPH. And BPH, of course, is a common. It might be present. It is possible to have an enlargement of the prostate without any symptoms, but at times without actually having making the diagnosis. So the prevalence actually increases with age. It is estimated, or actually studied, that 8% of men aged between 31 to 40 years old have BPH, and 40 to 50% of men, and it affects more than 80% of men who are 80 years old and above. So there are other factors that come into play, including obesity, a high body mass index, and the lack of exercise. So a sedentary lifestyle actually contributes to the development of BPH. The causes are various, and the main cause that we have is in relation to the direct effects of testosterone on the prostate tissues. So this effect of testosterone on the prostate tissues actually has to do with the hormones that are produced, or that the testosterone actually leads to. So usually when we have a normal production of testosterone, it is usually because we remember that testosterone is a testicular androgen, but of course so produced in the adrenal gland. So actually, 95% of testosterone is produced from testicular tissue, and then the other 5 is produced from the adrenal glands, which is actually important when we look at the pathophysiology of prostate cancer, which Dr. Marvin will take us through. But we remember that we have dihydrotestosterone, which is produced as an effect of the testosterone. So usually it interacts with the prostatic epithelium and the stromal tissues. So in that case, it has a direct effect in promoting the enlargement of the prostate. And then we have other risk factors, which include metabolic syndrome. So when we talk about metabolic syndrome, it's a combination of various entities or various conditions. So we are talking about presence of hypertension, glucose intolerance or resistance, and then we might have dyslipidemia as some of the causes. We had already talked about obesity and the sedentary lifestyle contributing to the development of BPH. So we also have a genetic predisposition. So this is mainly associated with people who have first-degree relatives that have had the BPH. So if someone has either a parent, a father, or brothers that have had the BPH, they are at a 4 times risk of actually developing BPH. Then, in as much as the pathophysiology is concerned, it is important to remember that they are what we call static obstruction and also dynamic obstruction, which are the 2 main components that have to do with the development of lower urinary tract symptoms and the blood outlet obstruction, specifically in men. So when we have a static obstruction, it's actually a direct consequence of the urethral compression and bladder outlet obstruction. Static component, the periurethral, it's because now the periurethral compression requires an increased voiding pressures to overcome the resistance. So the patient actually has to push in order for them to be able to pay. Additionally, also is enlarged, causing obstruction to the overflow. We also have the dynamic components, which includes the tension of the prostatic muscles, stromal tissues. So this has to do with the decrease in the elasticity and collagen in the prostatic urethra. So of course, this can go hand in hand with the static components, and it's of course it may explain why the prostate size alone is not always a predictor of the disease. Now coming into the diagnosis of a patient with the BPH, it is important to note that the diagnosis is as we do with other conditions. The history is an important factor. History is an important factor, and then you have investigations. We have history, physical examination, and then we also have the investigations that are performed for these patients. So I'm seeing the questions that are popping up. I will attend to them when this topic. Okay. So in as much as need the hospital past if they have basically a glucose intolerance factors that have to be taken into consideration as part of the etiology. So all of that history has to come out. But now specifically for BPH, we also have to focus on specific, on the symptoms that the patient has presented with. So that includes the onset of the symptoms, the timing, exacerbating factors, and relieving factors. So the symptoms that the patient will present with are majorly divided into two. So we have what we call storage symptoms, and we have what we call voiding symptoms. So the storage symptoms have to do with the frequency the day or in the night. Of course, how to so we were still looking into the symptoms, and we were saying that the inability to urinate is one of the factors that comes into play when we are having BPH. And also the patient might actually have trouble stopping or starting a urine flow. So that also is in relation to that, they have to strain. So the straining actually increases the pressures within the bladder, and then gradually forces the prostate to open
The network. I hope that we can fight on and see how to finish. But I think I think Dr. Sikhondze should move on. He has told me he's in open space. The network may just be bad, I think. So be patient. When you hear the voice not good, then we may have to start again.
unfortunately, you might hear some background noises. We mentioned the metals of osmosis that is present. So all of those have to be ruled out. So an important specific part of the examination, of course, is the digital rectal examination, which should be done with the patient. I want to believe that we know the different positions in which we can put a patient for digital rectal exam and actually performing the procedure so in patients who have BPH, the findings will be of a smooth enlarged prostate. So it is important to determine whether it is the lateral lobes or the median lobe that are actually enlarged in this patient. But as you continue, you will be able to get the skill on how to differentiate the different lobes. And then investigations are an important part of the of making the diagnosis. And as we do investigations, we usually start with baseline tests, including a blood test where we do a complete blood count. We will also it would also be good to know the renal function of the patient, because we remember that if the prostate enlarges so much and there is a retention of urine that happens, so that retention can end up causing hydrouretas and ascending up to cause hydronephrosis in this patient. So we know that hydronephrosis affect the functioning of the kidney because of the obstruction. So it is important to determine how it is. And then the most sensitive test, blood test, in as much as BPH is concerned, would be the prostate specific antigen. So this one is actually done because we want to see how the prostate is actually functioning in this case. So it actually helps predict the prostate volume, and also it helps us to determine if there is no suspicion of any cancerous a condition that is occurring within the prostate. Of course, whenever you are doing a PSA, it is important to have into consideration some factors, including that the presence of a large prostate, the digital rectal exam itself, the presence of infection, catheterization, and prostate cancer can actually lead to an increase in the PSA levels. So some people advocate that if you are having a patient who is having the severe symptoms and they meet the criteria of the age, it would be good to take the blood sample before you do the digital rectal exam to determine the correct levels. But of course, it all has to correlate with the clinical picture that the patient has. So the standard is to do your physical examination, and then after the physical examination, you perform the investigations. So that is what we usually go by. And then the other investigations that are needed include a urinalysis. So urinalysis will help detect the presence of infection, which is usually shown by the presence of leukocytes or nitrates in urine. It might also help you determine if there is any microscopic hematuria which cannot be seen with the naked eye. And then we also be able to determine or diagnose any metabolic disorders that the patient might be having. And then the other modality of investigation is performing an ultrasound. So the ultrasound will help us to determine a number of entities. So this ultrasound can either be a transabdominal ultrasound, or it can be a transrectal ultrasound. So when you are doing a transrectal ultrasound, it gives you more details in as much as the prostate is concerned. But basically, the ultrasound will show us the prostate size, the volume that it actually has. And of course, the abdominal ultrasound will be able to detect if there is any hydroureter, if there is a hydronephrosis, and it will help in determining the residual urine volumes in the bladder. So in this particular case, what is done is that the patient, of course, usually sonographic studies of the bladder are usually better when the bladder is performed when the bladder is full. So the patient will usually be given fluid or encouraged to take fluid before the investigation. The ultrasound is done, and then you send the patient to actually void. And after they void or urinate, you again repeat the ultrasound to see how much urine has remained within the bladder. So also renal impairment can be seen because on ultrasound, because they will tell you how the renal parenchyma actually looks like. And it will help also to rule out other conditions like bladder stones or ureteric stones or whatever might be causing the obstruction. And then we also have the flow studies. So these ones are used to determine the volume of urine that is passed over a specific period of time. And they help to establish whether there is objective evidence of obstruction to the flow. And then we have cystoscopy. So cystoscopy is basically an endoscopic procedure of the urinary tract in which we introduce equipment through the urethra that moves towards the bladder. So we are able to see the anterior urethra, the posterior urethra, and also the prostate, which is what is of interest in this particular case. So we are able to see if the lobes are enlarged, or if and how much room is available for the passage of urine. So like I said, if there is an enlarged median lobe, we shall be able to see. Same thing with the lateral lobes. So what cystoscopy helps us with is first of all to confirm the diagnosis, and then secondly, it can help us to estimate the size of the prostate, and also plan later on for interventional surgery in these patients. Now, when going into treatment, which is the last aspect of my presentation, we have different modalities of treatment. We have observation, medical treatment, and then surgical treatment. So the observational treatment is also what is termed the watchful waiting, which is a process to manage patients by giving lifestyle advice. So whenever you decided to do watchful waiting, usually it is preferred in men who have mild symptoms, and then it usually consists of yearly exams, and no active intervention is usually taken, which means that there is no surgery that is done, and there are no drugs that are given to the patient. So what is important in these cases is that there have to be some lifestyle modifications, which include weight loss, reducing caffeine intake and reducing fluid intake, and also making sure that you reduce the risk of lower urinary tract symptoms. So this is basically what it is, what watchful waiting means. And of course, this is an entity that needs a lot of compliance, especially from the patient. So it is important to sit the patient down, explain to them what you are planning, so that they also comply with the recommendations that you have given them as a doctor. And then we have medical therapy. So medical therapy aims to address the static and the dynamic components that we had discussed about earlier on. And it includes some different entities, which are basically medicines that are given to these patients. So for the three main categories of drugs that are given are alpha blockers, 5-alpha reductase inhibitors, and anti-muscarinic drugs. So in as much as the alpha blockers, examples include the tamsulosin, alfuzosin, which are drugs that can be used to help, especially with the dynamic component of the BPH. So we have said that these ones, they're actually recommended in men who have mild to severe symptoms, and they usually provide the alpha blockers, they usually provide the adequate relief of the BPH symptoms, and their effect is almost immediate once the patient starts taking the treatment. So usually, once you start the alpha blockers, the patient needs about 3 to 5 days in order to feel relief of the lower urinary tract symptoms. And of course, as we have said, it is one of the proactive forms of treatment. But whenever you are giving the alpha blockers, we have to remember that they have their own side effects. So it is important to let the patient know, for instance, that they might experience a decrease in the blood pressures, because they're used for as antihypertensive drugs also. So the patient might have those ones. So that decrease in pressure and fatigue. So you have to warn the patient about those side effects of the drug. And then we have the 5-alpha reductase inhibitors, which include the finasteride, which addresses now the static component of BPH. So this one, it is of course done for men who have been confirmed to have the BPH, and it actually helps to reduce the need for surgery, and helps, like the alpha blockers, it helps to reduce relieve the symptoms. Of course, you have to inform the patients that the 5-alpha reductase inhibitors might have other effects, including erectile dysfunction or impotence, which are usually experienced during the period while the patient is taking the medication. There might be a decrease in libido, and there might be ejaculatory disorders that they experience while taking this medicine. So these are precautions and information that has to be given to the patient. And then lastly, we have surgery or surgical intervention. In whom the medical therapy or watchful waiting or medical therapy have not actually worked for the patient, or if the patient presents and they already have severe lower urinary tract symptoms which need urgent or intervention. So those who are having refractory urine retention just basically means those who have failed on the other therapy to try and reduce the prostate gland, and those who have recurrent urinary infections So other patients include those who have hematuria, that is refractory to medical treatment, those who have renal insufficiency, the presence of bladder stones, who have high postvoidal residual volumes, and then also those who have high pressure chronic urine retention. So there are different surgical options that a patient can undergo, and they are broadly categorized as minimally invasive techniques and open procedures. So the minimally invasive techniques include transurethral incision of the prostate, and then you have the most common one, which is currently the gold standard for BPH. We have the transurethral resection of the prostate, which is TURP. And then other places actually have started using laser enucleation, which is also referred to as HOLEP. But in our setting, we also perform the open. We also do the open prostatectomy. So the open prostatectomy has different variants, which include retropubic approach, a suprapubic approach, and a perineal approach. So it is important to, of course, sit down with the patient, explain to them the benefits and risks of each one of these surgeries before you actually perform them. So the advantage of the minimally invasive procedures, as the name says, there is minimum damage to tissues, that is non-related tissues. Unlike when you are doing open prostatectomy, where you have to make an abdominal, probably an abdominal incision. So that actually increases the patient's morbidities. So the risk of infection is high. Then also the length of hospital stay also becomes very high in these patients. And then this is just an overview of the treatment options that we have for these patients. So we have, just in summary, the watchful waiting. We have minimally invasive surgery, and then we have invasive surgery, which is open prostatectomy. So that brings me to the end of my evening. So
okay, thank you, Dr. Sikhondze. We shall take about 4 questions, because we need to proceed with cancer of the prostate, and Dr. Sikhondze and myself will be running the clinic. So we need to finish the lectures also, so that we don't delay the patients. So as usual, we shall take the questions by show of hands. We have some questions already in the chat box. Let me see. So the first one, Doctor, I will request for more clarity on the role of testosterone, on the role testosterone plays in BPH as the leading cause. Maybe let me just go through this very fast. So testosterone is produced in the testis. It's an androgen, and the prostate has what we call the androgen receptors, and that's where the androgens attach, and so the testosterone actually is not the most potent. The more potent one is the dihydrotestosterone, and that androgen actually attaches to the receptors, and that's what causes the BPH. So it's the leading cause, like you said. Let me see. I recently entered. Yeah, this is from Addison. Can this be used as a public health measure to increase early diagnosis of these? BPH, BPH per se, from the presentation, you must have realized that it's not a disease. BPH is not a disease. It is a normal response. It's like the old men get gray hair. You don't say because he has gray hair, he's sick. So BPH is normal. We come in when the BPH causes obstruction. And so it's fine if you educate patients early enough and let the population know that if you're not urinating well, it is not normal. Doctor, I've seen patients with patients on tamsulosin and doxazosin getting hematuria while on treatment. What can explain this phenomenon? There's no connection between using tamsulosin or doxazosin with hematuria. But the only thing you should know is that,
tell Jimmy to get for you, son.
So the only thing you need to know is that an enlarged prostate also can bleed. And we call that a bleeding prostate. So sometimes the prostate bleeds and you should not be surprised. Of course, when you get hematuria, you should also be thinking about other causes. And in such patients, it would be very important to do cystoscopy and see where exactly the bleeding is coming from. But just know that there is a diagnosis of a bleeding prostate. So there is no connection between the
Doctor, I had a question. When open prostatectomy is done, how often do we see?
Just hold on, don't worry.
Okay.
Just hold on. So more light on microwave therapy. All these methods are minimally invasive methods, and the microwave, of course, uses heat, and it's used. All these methods are just intended to reduce the prostate. So you may not get a chance to see microwave therapy, even in Kampala. I don't think even in Nairobi it is. The gold standard, though, is TURP. That is a transurethral resection of the prostate. And that brings me to the second question. Doctor, there is a high rate of recurrence with TURP procedure. How effective is it? TURP is it is the gold standard for managing BPH. And Dr. Sikhondze, I think, told you when to do open prostatectomy. It is very effective depending on who is doing it and the case selection. If the prostate is 80 grams and below, some literature will talk about 60, but 80 grams and below, you can safely do TURP to total completion, total resection of the prostate, and the recurrence should not happen if you've done complete resection of the prostate. Then recurrence should not happen until 8-10 years. So that's a long time. But it is true that the advantage of open prostatectomy is that the recurrence rates are much less. I think testosterone also inhibits, this is not a question. Okay, so I have tried to go through these questions very fast so that I give chance to some few questions by raising hands. So we have Miro, Emmanuel. You will ask your question. We'll only have, let me see. We only have 3 questions here. Oh, there are many. 1, 2, 3, 4, 5. So we shall only take these 5 questions. We shall not add more. Dr. Sikhondze, I hope you are still online. I tried to summarize the other ones, but I'm happy if you take on these ones that are coming. I see Miro Emmanuel.
Yes, thank you, Dr. Sikhondze and Dr. Mwesigwa. So I have 2 questions. The first question is about herbal practitioners who tell patients who have BPH to use herbal supplements like tomatoes and everything which have dietary nutrients. So in patients who have moderate to severe symptoms with BPH, can these dietary nutrients or supplements these people advocate for reduce the symptomatic progression in BPH? And then the second question is
no, we said one question at a time.
Got...
Miro, please ask one question.
Oh, okay.
Yes, one question, because others also must have an opportunity, and I told you what we are running to do after. So one question each.
Okay, one question then. Yeah.
Okay. Yes, in relation, we did talk about the importance of lifestyle modifications. When it comes to the management of BPH, that is during the watchful waiting. Of course, there are many theories and literature that has been done in a lot of urologic conditions. They have looked into the aspect of patients using these red vegetables and foods in the process. Okay, naturally red foods, of course, in the reduction of BPH. But it is not something that on its own can actually eliminate BPH. It has to be in adjunct with the other things that we discussed here. So it does have influence, of course, patient should do. Then we'll take a question from Mujeni. Alan, please unmute and ask your question.
Thank you, doctor. I was asking about in the medical management, why you didn't put androgen receptor blockers or any androgen? Do we use them or we don't use them in BPH? Thank you.
Okay, thank you very much for that question. So if you would remember from what Dr. Marvin was explaining, we were talking about the dihydrotestosterone epithelium and the stroma. So need to remember that it's actually produced it is converted into dihydrotestosterone by the 5-alpha reductase. So we remember that as part of the treatment, we said that we give the patient the 5-alpha reductase. That is what we are doing in as much as targeting the androgens is concerned. I hope that answers your question. Yes, so I'll take from Jonathan, your question, please.
Yes, thank you so much. So I was saying, how prevalent, my question would be in relation to the open prostatectomy, how prevalent is retrograde ejaculation and erectile impotence secondary to that surgery, the open prostatectomy?
Okay, thank you, Jonathan. So we have to to remember that when we are having a patient that have BPH, it is important to actually look at the whole patient themselves. So all of those issues of erectile dysfunction have to be asked about from the patient before any intervention is taken, because we said that some of the conditions, including diabetes, hypertension, are part of the risk factors. So those conditions, together with the presence of the BPH, might result in a certain degree of erectile dysfunction in these patients. So it is important to talk to the patient about those, and also make sure that we inform them, especially with the medical given, they shall cause some erectile dysfunction. So in as much as the procedure is a concern, the open prostatectomy versus the TURP, so it is important to let the patient know that especially with these procedures, they might have problems with the ejaculation, because you have what we call retrograde expulsion of the sperm. So instead of going into the urethra, you might have some of the sperm going backward, retrograde into the urinary bladder. So those are aspects that are important to tell the patient about, and they are present but not very common phenomenon. Okay, thank you, Dr. Marvin. Shall we take any other question or?
So that was Mujenye.
That was Jonathan.
That was
Mujenye had asked the question already, I think.
Okay, so I think those questions are enough. I think they were well addressed. I just wanted to supplement. There's someone who asked that we have not included anti-androgens in the management of BPH, and the anti-androgens are not used. Anti-androgens are only used we usually get a few challenges here and there. Sometimes I also go off and have to get back on. So don't feel very bad about it. The internet sometimes can disappoint. But thank you very much. And
thank
to
you,
the students, I hope they have learned a lot. So without wasting time, I think we shall move to prostate cancer. And after what Dr. Sikhondze has taken us through, this should also be should also not be very long. So we can also look at prostate cancer, and prostate cancer is the leading cancer diagnosis and the second most common cause of cancer-related death in men. In the US, it is not very different. It may actually be worse in our situation because, as we shall see in this slide, prostate cancer is commonest in Blacks, in Africans. Whether they are in Africa, whether they are in America, whether they are in Asia, as long as you're African, research has shown that cancer is more common in the Africans. Worldwide, prostate cancer is the fourth most common cancer in men, with incidence and mortality rates that vary markedly among and within different countries. Of course, the incidences are more in countries where screening is done more. for countries where the screening is not done, like in the developed countries, then you have less reported cases. In other words, you have a false low incidence. But in those countries that do screening, they pick more cases. So you tend to find that their incidences may be reported more. So like we've said, this cancer is mostly in the Africans. And this one is more really in the whites and the Hispanics. It's not as common as Africans, irrespective of the environment, whether you're here, whether you're in Europe. As long as you're African, you're more predisposed. It is predominantly a disease of the elderly men, and due to the screening, the age and the stage of the disease have been reducing. Of course, this is not true for our setting. Some of this data is for developed countries. In our situation, because of less screening, the age and the stage of at which we make the diagnosis are still high. It is not rare to see patients already with metastatic disease, for example. Now, in the risk factors, both genetic and environmental roles are reported to play a role, but there are some that have a lot of controversies around them. The ones that are universally considered as risk factors is age. In other words, increasing age. If you get a patient who is 80 years and another is 50 years, the one with 80 has more chances of having cancer of the prostate. So age is one that is accepted by everyone. Then you have the issue of inheritance. If you have a father who had prostate cancer, then you should start screening earlier. You should start screening at 40, 45, compared to those who don't have any history, any predisposing factors. You may advise them to start at 50 years. The rest, like we've said, if you're African, then the chances of getting cancer of the prostate are high. Of course, androgens are involved. We've talked about androgens in BPH. They are also thought to be very responsible in prostate cancer progression, and we shall see that later. Now, the three first, these three that I mentioned first, the age, the inheritance, and the race, as you can see, you cannot control them. And we've said they are the most recognized risk factors. You cannot control your age. You cannot control your relatives. You can't decide who your father is, who your uncles are. And you can't decide whether you are African or Asian or... So that's why it's important to always think about the component of screening, so that you get these cases early. Of course, androgens, we talked about them. Diet also has a lot of controversial issues. Some people are for it, some are against it. So there are controversies there. Sexual activity is believed to also predispose the patient to infections. And some scholars think the infections may actually end up predisposing to prostate cancer. But more recently now, in the recent years, another aspect of the sexual activity has come out, and I'm sure some of you have met the research that shows that if someone ejaculates 21 times a month, that protects them from prostate cancer. Like I've said, of course, alcohol, smoking. Like I've said, the diet issues, the sexual activity, alcohol, smoking, they are controversial issues, and you should take age, increasing age, the race, and the inheritance component of it, of course, and androgens. Now, in the pathophysiology, prostate cancer arises from the peripheral zone. And that's why when Dr. Sikhondze was presenting, he talked about a digital rectal exam. And I think there was a slide that was talking about red flags. When you do the dictorate exam, there are some red flags if you find the prostate is hard, nodulated, and the like. So when you do a dictorate exam, what you're feeling is actually the peripheral zone. And so that's where the prostate cancer arises. Most of the cancers are adenocarcinomas, about 95%, but there are other cancer types that the when we take off the biopsies and we send them to the pathologists to read, there's certain information we want, and that is the type, first of all, and we've said that usually want from them is something we call the Grierson score. The Grierson score is from 2 to 10, and the Grierson score just describes the differentiation of the cancer cells. So we know that when you're talking about differentiation, it means if you had a normal cell and you had a cancer cell, you want to see how close the cancer cell looks close to the normal cell. So the Grierson score considers the okay, and one is the cell that is close to the normal cell. Number 2 is farther a bit. Number 3 is different. Number and so the tumor cell is, and so the better the prognosis. And so the Grierson score is 1 to 5. And so when the pathologists look at the slide, they will score the most predominant pattern. If, say, for example, the cells are very poorly differentiated and they are scoring 5, so the most predominant maybe will score 5. And then they look at what is the next pattern. And the next pattern, if it is well differentiated, close to the normal, then maybe it will score 2. So the score of that patient will be 5 plus 2, and that makes 7. So that's why I was saying the Grierson score scores from 2 to 10. And the more the number, the higher the number, the more poorly differentiated the prostate cancer is. Now, in the diagnosis, the clinical presentation of the patient can present with features of bladder outlet obstruction. In other words, prostate cancer can also cause bladder outlet obstruction. And we've already, Dr. Sikhondze talked about the LUTs, the lower urinary tract symptoms. So you may have symptoms in relation to bladder outlet obstruction, and those will be LUTs. And then you may have features of regional disease. You may also have symptoms arising from metastatic disease, bone, liver, lung, spine. These are patients you may find the patient has lower unit of the lower limbs. We know that prostate cancer commonly metastasizes to the lumbosacral region because of the valveless veins of Batson, and so it's one area that gets the metastasis earliest. And so if you ever see an elderly man with lower urinary tract symptoms and also has paraplegia of the lower limbs, this patient has bladder outlet obstruction second with metastatic disease, to the lumbosacral spine, unless proven otherwise. Of course, in the majority of cases, especially in the developed countries, these patients mostly will have no symptoms, and they may be picked through screening. We say you do a PSA, it is higher, you do a rectal exam, and then you diagnose the cancer. Majority of the patients will have quiet disease until the disease is advanced, and that's why we emphasize screening. If most of the times, if you see a patient who has already had symptoms, the disease is may already be metastatic, and so we need to keep looking out. So on examination, you want to see the general condition of the patient. The patient may be wasted, they may be pale, because advanced prostate cancer causes severe anemia. The patients may have lower limb edema because of lymph node metastasis. They may have paraplegia. They may have lower back pain, severe lower back pain. They may have they may have lower back pain. Paresthesias also in the lower limbs especially. And an important aspect is the digital rectal exam. The prostate will be found to be hard instead of firm. It will be nodular instead of smooth. And the median sulcus may be obliterated. The rectal mucosa may be adherent. So the rectal mucosa may be fixed and not really mobile. And of course, there may be some involvement of adjacent organs. This slide, I hope, is clear. I think we would also have had it in the previous presentation. It is very important. It is called the IPSS, and it is important in scoring the lower urinary tract symptoms. And so you score the lower urinary tract symptoms considered are 7, and you consider them to each to score 1 to 5. Okay, 0 to 5. And you, as you see from the diagram, you consider 0 if the symptom is not at all, it is not there at all. Say if you are talking about incomplete emptying, all these symptoms, you ask the patient considering the like 1 month backwards. Okay, so over the past 1 month, you ask them, for example, over the last past 1 month, how many times have you had incomplete bladder emptying? If they say not at all, you score them 0. If they say less than 1 time in 5, you score them 1. Less than half the time, 2. About half the time I've urinated, 3. More than half the time I've urinated, 4. Almost always 5. So you score each symptom like that, and then you get the final score. And we already said that the symptoms are 7. I hope you can. This is the previous slide. So you can see this incomplete bladder emptying, frequency, intermittence, urgency, weak urine stream, straining, and then nocturia. So in total, there are 7. And therefore, the highest score becomes 35, because 7 times 5 is 35. But the other aspect that you should take very seriously is the quality of life. And this quality of life, you should ask the patient, for example, if someone is a surgeon, like myself, you should ask them, these symptoms you have told me, are you unhappy? Are you, in other words, in relation to your work, for example, are you satisfied? Are you dissatisfied? Are you unhappy? Is the problem terrible? If, say, when operating, I have to ask my assistant to hold on, and then I have to unscrub and go to the loose to pass urine and come back and continue with the surgery, I think I would classify that one as terrible. And if I am not affected in any way, maybe I'm delighted, I'm pleased, I have no problem with this issue. So as you consider the IPSS score of maximum 35, then you should also know that there is that component of quality of life, and you should ask the patient. They will always score it also. So the score is not complete until you have also reported about quality of life due to these symptoms. And of course, Dr. Sikhondze talked about the severity of the symptoms while talking about management. That if the symptoms are mild, moderate, and severe, these are the treatment modalities you use. And this IPSS is what you use to actually categorize those symptoms. So in the investigations, we have the prostate-specific antigen. It is generally considered to be 4, that 4 is normal, but please remember that you also must look at it in relation to the prostate size, okay? Because remember, Dr. Sikhondze talked about using PSA to predict the prostatic size. So when you're reading the prostatic specific antigen values of a patient, you should have in mind the prostate size. It could affect it. If the patient has a huge prostate, it may give you a higher PSA than 4, and yet is normal actually. Of course, the other thing is you should also consider the age. So you will meet things that have been used to improve the PSA. You things like PSA velocity, doubling time of the PSA. Of course, the other investigation is the transurethral ultrasonography. Transurethral ultrasonography is much more sensitive compared to the abdominal scan. The abdominal scan is not as good as the transrectal one when it comes to the prostate. And this is good because it also gives you nodules, okay? It can give you nodules, it can give you how the capsule is, whether it's intact. It can give you the size more accurately than the abdominal ultrasound scan. True cut biopsy is of course what you do if you suspect that the patient may have cancer following your PSA and your dictorectal exam. And the true cut biopsy can be done with ultrasound scan guidance or just a finger. We commonly use a finger because we don't have a probe. We don't have ultrasound for this procedure. And when we get the tissues, you send them to the pathologist, like we said, and the pathologist will tell you the type and the Gleason score, and then you decide on the way forward. Of course, staging investigations include the chest X-ray, the CT scan of the chest. You can have a bone scan. We don't have a bone scan here. I think even in Kampala, there is none. There is one in Nairobi. So instead of the bone scan, we usually use the lumbosacral X-rays. And we already agreed that the commonest site of the metastasis is the lumbosacral X-rays. Let me see. Okay, I was just checking in the chat box. So lumbosacral X-ray, an AP and the lateral views is very helpful. Of course, it can miss some because the bone scan is the best. An abdominal ultrasound scan, Dr. Sikhondze went through what information it may give you, or better still, a CT scan. It is important also to have a full blood count because the cancer itself causes anemia, especially when there are metastases, bone metastases. Liver function tests, renal function tests, all these are very important in terms of not only metastases, but Dr. Sikhondze talked about how blood outlet obstruction may cause renal insufficiency. If there is obstruction, sometimes you have hydroureters, hydronephrosis, And of course, this will lead you to renal insufficiency in patients with bladder outlet obstruction. Now, the staging of the cancer, we use the TNM, and so in the T, what is important is, of course, cancer in situ, or what is called PIN. This is not usually considered as malignancy. If you find it, you should treat the patient as if there is no cancer. But what is important is T1, T2, T3, and T4. And T1 is into 1A, 1B, and 1C. And 1A and 1B is dependent on how much of the resected tissue is found to have cancer. Remember, when Dr. Sikhondze was talking about BPH, he talked about TURP, okay, transurethral prostatectomy. And when you resect this tissue, then you should send all of it to the pathologist, and they should actually examine all the tissues ideally. And if less than 5% is has cancer, then it is T1A. If it is more than 5, it is T1B. If this cancer is detected by elevation of PSA alone, normal digital rectal exam, and the TRAS, then you should consider it as 1C. And then T2 is cancer that is limited in the prostate, and it depends whether it is in one lobe, whether it is in both lobes, and how much is in one lobe. You read about these things. Then T3 is extra capsular extension. And 3A, you can have extra capsular extension on one or both sides, but 3B involves the seminal vesicles. And of course, T4 extends into the bladder neck, the sphincter, rectum, levator ani muscles, or even the pelvic wall. And the N also has, there may be no regional lymph nodes, or there may be metastases to the regional lymph nodes. It is not rare to have patients with CA prostate, and they have edema of the lower limbs. Why? Because of the involvement of the inguinal lymph nodes also. Of course, pelvic lymph nodes are also involved. And then for metastases, you may have metastases to non-regional lymph nodes. You may also have distant metastases to bone. We talked about that the lumbosacral spine is a vertebrae, are the most commonly affected. And of course, you may have distant metastases to other sites. So in the treatment, when you have cancer of the prostate, it depends on whether it is localized or whether it is metastatic. And like any other cancer, we know that if it is localized, then you have chances of curing it. If it is metastatic, then you may have to only do palliation. So it is the same as prostate cancer. But the other important thing we also consider in the localized disease, so we are starting with the localized disease, that is T1 to T2. And we still remember the T2 when the cancer is really localized, because we say T3 is extracapsular disease, which may also involve the seminal vesicles. So this one is for localized disease. That means the prostate cancer is still in the prostate. Now, the other important factor we consider is life expectancy. So if you have a patient whose life expectancy is less than 10 years, then you should not do what we are going to talk about. You should not be too aggressive, and you may want to do what we call watchful waiting, okay? If life expectancy is more than 10, 15 years, then the objective should be to cure the disease. Why? Because the methods that we are going to talk about, that is radical prostatectomy or radical radiotherapy, are the only curative modalities for prostate cancer, which is localized, okay? So the only curative treatment for localized disease is radical prostatectomy or radical radiotherapy. But research has shown that for the patient to really benefit from these huge treatment modalities that come with serious side effects, the patient must have life expectancy more than 10 years. If the patient has life expectancy of less than 10 years, please don't subject them to these methods. Because of course, what limits life expectancy, these are things like comorbidities, okay? Maybe someone has uncontrolled DM, uncontrolled hypertension, they have malignancies in other places, and they don't expect them to live for 10 years. So you should not go into radical prostatectomy or radical radiotherapy. They may not withstand this, and they may have their life actually worsened, their lifestyle. So for life expectancy of less than 10 years, you can do watchful waiting. Watchful waiting means you don't do anything. You have seen the patient, you tell them, we've seen your cancer, but we shall do nothing. Just go home, enjoy your life. You may die of other things. Then if life expectancy is more than 10 to 15 years, then you should do radical prostatectomy or radical radiotherapy. These two both give you the same results in terms of curing the disease. In the follow-up, the levels of PSA should drop to 0 post-op. This is true for radical prostatectomy. Radical prostatectomy is surgical. You operate and remove the whole prostate with its seminal vesicles, okay? So for radical prostatectomy, if you have done complete excision of the tumor of the prostate, then the PSA levels should drop to 0 post-op, okay? For radical radiotherapy, it is different because the mechanism of action is different. For surgery, you remove the tumor. For radiotherapy, you don't. Radiotherapy works by causing what we call lethal mutations, okay? Lethal mutations. In other words, the cells, as they divide, they will reach a stage where they will have to die. Yeah? That's why we call them lethal mutations. So after radiotherapy, don't expect the PSA to go to 0. But for surgery, the PSA should go to 0 since you have removed the prostate. The complications of radical prostatectomy include urinary incontinence and erectile dysfunction. And that's why you have to be very serious in explaining to the patient what the benefits of the radical prostatectomy are versus the complications that could arise. That is urinary incontinence and erectile dysfunction. Now, in the local advanced disease, that is T3, we prefer to use radiotherapy plus or minus hormonal deprivation, or what we call hormonal manipulation. We'll see it a bit later. In the advanced or metastatic prostate cancer, our intention is to do palliation. Sorry. So the intention in the advanced disease or metastatic cancer of the prostate, the intention is to do palliation. And in this palliation, we intend to do symptomatic management, that is for pain, nursing care. We also want to have orthopedic management for pathological fractures, catheter care, maybe urethral catheter or SPC, a channel TURP. If the catheter is too bothersome, you can also do channel TURP. We can also do hormonal manipulation, and we still remember the hormones that are involved in the production of the androgens, okay? We shall see, I think, a picture later. So this hormonal manipulation can be medical or surgical. And of course, we can also have radiotherapy just to control bone pain, metastasis to the spinal cord. This diagram just shows us what we call the hypothalamus pituitary testicular axis, and you should look at it in your free time. But of course, you remember that the hypothalamus produces what we call the luteinizing hormone releasing hormone, and then that acts on the pituitary to cause it to produce luteinizing hormone and FSH, and it is the luteinizing hormone that works on the testes, on the Leydig cells to be specific, and these Leydig cells produce the testosterone, and the testosterone heads to the prostate, attaches to the androgen receptor. Let me just pick, let me pick a pointer here. So we are saying the pituitary produces the luteinizing hormone. The luteinizing hormone acts on the Leydig cells in the testes, and the Leydig cells produce testosterone, which testosterone goes to the prostate. And we are saying the prostate has an androgen receptor, okay? Androgen receptors. And of course, also has this enzyme, aromatase, and is responsible for producing the dihydrotestosterone, which we said is more potent. Well, the other thing I want you to appreciate is that the testosterone and estrogen also have a feedback, a negative feedback effect on the hypothalamus. And the other thing that I would like you to appreciate is that the testis produces 95% of the androgens, and the adrenal gland produces 5%. So the adrenal gland also has a contribution of the androgens. Please keep this in mind, because we shall look at it when we look at the different methods of the treatment, the hormonal manipulation. So when we talk of hormonal manipulation, this is the cycle we are trying to manipulate, to make sure that the prostate does not get androgens, because we say these androgens from the testis and from the adrenal glands is what causes the progression of the disease. So keep in mind that 95% of the androgens are from the testis as testosterone, and 5% adrenal androgens. So hormonal manipulation, so when we are doing hormonal manipulation, we are trying to eliminate androgens, because those are the ones that cause progression, very fast progression of the disease. And one of the methods is to remove the factory itself, okay? Because we've said majority of the androgens comes from the testis, okay? From the Leydig cells. So one of the hormonal manipulations is to do surgical castration. You castrate the old man, of course, bilaterally, and it can be total or subcapsular. These are just techniques in the surgery. But what you should know is that one of the hormonal manipulations, you can do surgical castration. The other, you can do medical castration. And what we use for medical castration can be estrogens, okay? And if you remember on the diagram we've just seen, we saw that testosterone and estrogen have a negative feedback on the hypothalamus. And therefore, if you give the patient estrogen, then this patient is likely to have that negative feedback effect, and therefore reducing on the production. We also have the luteinizing hormone releasing hormone agonists. We used to have the antagonists, but they were stopped. So we can have luteinizing hormone releasing hormone agonists and antagonists. And like I've already told you, currently we are using the agonists more. So we are using the luteinizing hormone releasing hormone agonists. Then we also have androgen blockade at the target cells. So these are the ones we call anti-androgens, okay? You remember the question in the previous presentation, I was very clear. I said, no, anti-androgens are not used in BPH, but they are used in prostate cancer. And these ones act on the androgen receptor, because we said when these androgens are produced by the testis and the adrenal glands, they actually go into the prostate and attach on the androgen receptor, which is in the prostate. And when they attach there, they cause progression of the prostate cancer. And so anti-androgens are those drugs that actually go to the receptor and attach there. They compete for the receptor in the prostate. And instead of the androgen attaching there, these drugs actually attach to the receptors, and therefore the androgens don't have anywhere to attach, no receptors, and therefore they can't cause effects. The commonest drug in this is bicalutamide. It's the one that we are using a lot, but these others are also on the market. And the luteinizing hormone, you meet something like Zoladex, and that is goserelin. These are the commonest that we are using. Now, the maximal androgen blockade, or what we call total androgen deprivation therapy. I want you to listen carefully so that you understand this part, because it's very important. Now, if someone has prostate cancer and you do surgical castration, for example, if you do surgical castration, you have removed the patient's testicles. That means you have removed 95% of the androgens, but you have not removed the 5% that comes from the adrenals. And therefore, if you want to eliminate the 5%, you do surgical castration and add an anti-androgen. In other words, you remove the testicles and also block the receptors in the prostate. And that's when we talk of total androgen deprivation therapy, or what we have also called maximal androgen blockade, okay? Now, if we only do surgical castration, that means we have only done androgen deprivation therapy, ADT. Let me repeat it for clarity. If you do surgical castration alone, you have done ADT, androgen deprivation therapy. If you do surgical castration and add an anti-androgen, you've done total androgen deprivation therapy. Total, because you have now blocked the 95% and the 5%. So when we talk of maximal androgen deprivation therapy, it means we are talking about blocking 100% of the androgens, okay? And you do that by doing either surgical castration or medical castration. And when you do those, you add an anti-androgen. And that's how you achieve the 100%. Now, the castration does not come innocently. It has side effects. And so before we do it, it is good to advise, to explain to the patient and get informed consent and be open about it. Tell them you will have gynecomastia, you may have libido and sexual dysfunction loss. You may also have osteoporosis. They usually get muscular atrophy and increased fat. And of course, with the increased fat, they may get insulin resistance. So they may also get diabetes. They also get anemic. They get hot flashes, and they may also get cardiac disease. And these side effects usually happen, either one or two. So you need to really, like loss of libido will happen, and sexual dysfunction will be there. And they usually also get a lot of sweating, a lot of hot flashes. So you should counsel them and tell them about these side effects so that they are not frustrated later. Now, as we conclude, there is another component called castrate-resistant CA prostate, or it is also called androgen-independent CA prostate. So when you meet this phenomena, don't be confused. And for you to talk about castrate-resistant CA prostate, it means that the patient has been on total androgen deprivation therapy. I've just talked about it in detail. We said for you to achieve total androgen deprivation therapy, the patient should have surgical or medical castration and also have an anti-androgen added. In other words, you are blocking the 95% and the 5% from the adrenals. So you expect that the patient has a complete deprivation of and the 95. Now, we already said that our belief is that prostate cancer progression is because of androgens. So our expectation is if you block all the androgens, then the patient should be okay. They should not be any problem. And that is not the case. The case is actually that when you have patients with metastatic disease, and even if you do the total androgen deprivation therapy, these patients will live for ranging from 1 year to 36 months. And after that, the patient actually starts getting problems again. Okay, they get PSAs that are very high. They start getting metastases that cannot be controlled. Resistant CA prostate. If we believe that prostate cancer survives only on androgens, then why is the patient deteriorating after 3 years? So, in other words, that's why we are saying for you to talk about this castrate-resistant prostate cancer, the patient should have 100% blockade of the androgens. 2, for you to diagnose it, you should have testosterone levels that are less than 50 nanograms per deciliter. If you have testosterone that is more than 50, then it means you have not achieved total androgen deprivation therapy. Because total androgen deprivation therapy achieves testosterone levels less than 50 nanograms per deciliter. So for you to talk about this castrate-resistant prostate cancer, the testosterone should be less than 50 nanograms per deciliter. Now, there are some theories that have been looked into why these patients of the testosterone. And one of them is that the receptors develop what we call receptor promiscuity. I know all of you know what the word promiscuity means in terms of human beings. And so the receptor is to accept the cytokines and growth factors. It is believed that instead of the receptor only reacting to the androgens, growth factors and cytokines can also attach to these receptors and cause progression of the disease. Of course, anti-androgen let me see. So the only, which could say that the patients for orchidectomy or hormone manipulation are patients who already have metastatic disease. Okay. Yes. Some urologists request for acid phosphatase test. Is it more sensitive than PSA test in the diagnosis? It is not. It used to be asked for. It is yeah, they are just, it's used, it was used long time. PSA, the told you about use including PSA velocity, PSA doubling, all the PS. So you can do those modifications, including free PSA. So someone was very sad about it. It is understandable. We do prophylactic because we want you to go and read about the flare phenomenon, okay? The flare phenomenon of luteinizing hormone releasing hormone agonists. And you can prevent that by giving an anti-androgen, okay? Some literature will say you give an anti-androgen for a week before you start your luteinizing hormone releasing hormone agonists. So this is a very important question, and I hope I have addressed it in a very clear way. Miro, unmute and ask your question, please.
Okay. Thank you, Doctor. So my question is, in our resource setting, where probably we can't measure the densities probably of PSA, how do you use the PSA itself as a cutoff to know when to order prostate cancer? Because PSA can be elevated in both BPH and prostate cancer. So the patient is concerned and they're anxious that they may have a cancer and they have BPH or prostate or early, let's say early prostate cancer. Which cutoff value do we use to doing prostate biopsies?
For that question. So first, free PSA is also very good, okay? Free PSA is also a very good way to predict prostate cancer. But the other thing is not all patients with an elevated PSA will have prostate cancer. We know that prostatitis also increases it. So as a standard, we treat the patients with elevated PSAs with an antibiotic for a month, okay? And after that 1 month, you repeat the PSA. And if it is still high, then of course, you want to go in and take the biopsy. So you should generally consider 4 as the normal, but you should also consider things like prostatitis. So you should treat for prostatitis before for 1 month, and then you repeat the PSA. If it is still high, then you should take a biopsy. Of course, the density, you can get the grams, you can get the prostatic grams from the ultrasound scan. Although we already said that the transurethral ultrasound is the best. But you can use free PSA. You can also treat for a month and repeat the PSA. And you can also use the doubling time, for example. If you do the PSA today and it is 2 and you do it after 6 months and it has doubled, then that doubling time is a very short time. So in other words, PSA still has its challenges, but If you have those modifications, including free PSA, then you can make your decisions. And of course, the other thing is symptoms. You must also correlate with the symptoms. Say some cases are obvious. A patient, I already told you, if a patient has lower urinary tract symptoms and also has paraplegia, for example, PSA is more than 100, then there is no question. You should go ahead. Yeah, thank you. So with that, I want to believe that we have benefited from these lectures, and I encourage you to go and read about CA prostate and appreciate these things much better. If you only use the lectures, I think it will be very unfair to yourselves. It is good that you go and read and add on to what we have presented to you. You'll be able to appreciate these things much better. With that, I would like to wish you a nice weekend, and I would also like to advise you to continue taking care. There's a rumor that the third wave is starting somewhere, so you take care of yourselves. Enjoy the weekend.